Hello, this is Dr. Richard Bernstein with the November 2021 issue of Dr. Bernstein's Diabetes University. Before we go into questions, I want to disclose one bit of information that may be true, I'm not certain, but it has to do with COVID-19 vaccinations. And it was passed on to me by one of my patients who's a physician. She had the Moderna vaccine several months ago, about 2 months ago, and shortly thereafter, she had severe stomach cramping, diarrhea, discomfort that lasted several weeks, maybe 2 or 3 weeks. And I sent her to a gastroenterologist who did stool cultures and all kinds of testing and could not figure out what was wrong with her. However, she had patients who lived near her and were getting, most of them were getting Moderna vaccine because that's what was locally available. And she noticed that they were complaining of the same symptoms. Those who did not receive Moderna vaccine did not have those symptoms. She therefore called the medical department of Moderna, and they disclosed to her that 23% of the recipients in their post-market reports, 23% had gastrointestinal symptoms. Now, this is one person telling me it's hearsay evidence, but I figured I have to pass it on. I'm sure it's not because she was diabetic. I'm sure it's related to the vaccine, and that even if you're not diabetic, if this is really the case, that non-diabetics would get similar symptoms. That's basically the story. Now, before we get into the questions, I want to remind you that my answers are really designed for the bulk of the listeners to be educational and not necessarily correct for the individual who asks the questions. I can't have a high likelihood of being correct because I haven't met the patient, I haven't examined him, I have not seen his laboratory reports, etc., etc. So I don't know the patient who's asking the questions, and I'm just guessing. So take my answers as guesses and that are intended to educate the listener. My son is 3 years old and was diagnosed with type 1 diabetes a little over a year ago. From further testing, it appears that my son has a genetic variant of the HNF1 alpha gene, which points to monogenic diabetes, MODY3. Now, monogenic means that apparently one gene abnormality or change caused this diabetes. Research has indicated that there may be 100 or more different genes that are involved in the etiology of diabetes, especially type 1 diabetes. And for any given individual, there usually are at least several genes that can be found to be abnormal or posing problems. So when it seems that only one gene is causing the problem, they call it MODY. and this person apparently has MODY number 3. They treated him with sulfonylureas rather than insulin. Well, sulfonylureas are used to cause the pancreas to make more insulin. And they figured that if he had this form of diabetes, he still has a lot of active beta cells, and you can push them to make more insulin. As many of my listeners know, it's not a very good idea because eventually you've overworked the beta cells and they no longer function. In fact, the scientific literature says that the sulfonylureas and similar drugs are good for about 2 years, but the literature does not tell you why. It just says that they stop working, but they stop working because there are no more beta cells left. I know you have stated that you don't recommend sulfonylureas as they burn out beta cells, but I know that this was also in the context of type 2 diabetes. Does this still apply? I would certainly think so. I wouldn't want to give a sulfonylurea to my son. I would rather use small or dilute doses of insulin to treat this form of diabetes. His A1C is 7.4%. I'm sorry, scratch that, 4.7%, which is very good. It's because he's making insulin. He experiences more hypoglycemia than I would like, and I am wondering if he would be better without the insulin. It could be, but I would first want to experiment with diluted insulin, and as you can read in my book, Diabetes Solution, there are only certain insulins you can dilute. And that reminds me of another special subject that I should have mentioned today. I only recently discovered that veterinarians are using Protamine Zinc insulin on dogs and cats. This is the same long-acting insulin that I used when I was a child, except that it's now derived from human insulin molecules rather than beef or pork insulin molecules. So you can get Protamine Zinc insulin either from a veterinarian or from a veterinarian supply house. Furthermore, compounding chemists can get Protamine Zinc insulin. And this is the only long-acting insulin available today that we know can be diluted. NPH can be diluted, but it's not long-acting, it's intermediate acting. The old Ultra Lenti, which was very good, was dilutable, but it's no longer available. So if you have a small child and need to make diluted long-acting insulin, you have to figure out how you can get hold of Protamine Zinc. And probably the easiest way is through a compounding chemist. The regular insulin and Lispro or Humalog or Novolog insulins are all dilutable, but that's about it. Regular, Humalog, Novolog, those are rapid acting, and the long-acting Protamine Zinc is now available. This is important news. It probably has been available all along, and I just didn't realize it. My doctor is prescribing me exenatide to bring my cholesterol down. Do you ever recommend its use? This is a substance that reduces the absorption of saturated fats and may bring down cholesterol, but there's the serious question, is there any value to lowering cholesterol? And as far as I can determine from the current scientific literature, there isn't. If you can lower oxidized LDL, which is a cholesterol variant, or lower small dense LDL, that's another story altogether. And we don't know if the exenatide has helped lower those levels. The major factors in the blood that predict heart disease are inflammatory agents or inflammatory markers. And I don't think there have been any studies to show whether exenatide lowers inflammation. It certainly does not cause the adverse effects that statins cause. Doesn't cause muscle breakdown, muscle pain, and so on. Should I cut down on my saturated fat intake for the purpose of lowering my LDL? Chances are that it won't work if you're looking at the types of LDL that I just discussed, the harmful types, namely the oxidized LDL and the small dense LDL. But you can experiment, see what happens, but make sure that that's what you test, not the total LDL. My guess is that it's the inflammatory markers that will probably be associated with these more harmful forms of LDL. My son's endocrinologist says that my son is developing diabetes. He had 109 milligrams per deciliter fasting glucose test, though he still also often has about 83. He also has positive multiple antibodies. And you may recall that earlier in this lecture, I said that many type 1 diabetics have multiple antibodies that predispose to diabetes. The endocrinologist says he doesn't need insulin yet because he will be too sensitive to it and it will drop him. I asked the doctor if I should use a continuous glucose monitor, but he says I should just check his glucose at bedtime and in the morning, and to call him if the glucose is 200. I read your book and I keep my son on a low carbohydrate diet. I try to keep him in the range 80 to 120, but I saw 142. These still are not in the diabetes range according to the ADA. But what are the real criteria to start using insulin, and how often should I check his glucose? Well, first of all, I think that patients should be allowed to decide how to proceed when there's a borderline situation like this. And they shouldn't be dogmatically instructed by endocrinologists to keep their blood sugars high, to avoid taking insulin, and to encourage beta cell burnout, which is the situation here. You want to preserve his beta cells. And as I've said before, I've seen a number of patients where we've preserved beta cells for many years provided we catch the diabetes very early and keep the blood sugars normal. And this is because glucose, high blood sugar levels are toxic to beta cells. Now, here's an interesting question. I'll read you the whole question simply because this reader is from Croatia, and it's the only question I ever, or comment I ever got from Croatia. And he starts by saying he's not going to ask any questions, but he asks a lot of questions. I do not have any questions, but only to say that you are doing a great job for diabetic community worldwide, especially for us insulin dependents. I am a neurologist, psychoanalyst, and I teach at medical school here in Zagreb, Croatia, where I live. I am 40 years of age and was diagnosed with LADA, latent autoimmune diabetes of adults, a year ago, and am on Tresiba insulin, 14 units, and Fiasp, which is a rapid-acting insulin, 4 to 5 units ever since. My colleague diabetologist who takes care of me explains my great glycemic control, a result of my still active beta cells, which in his words is going to last for a year or more, and then I won't be able to control it like I do it right now. When I say that I'm following a low-carb diet and that I hope to achieve it indefinitely, he just laughs and thinks that I am just being unrealistic. The reason that I'm writing to you is that I see you are thinking the subject over a lot, and everything you say makes sense to me, myself being of medical education and all. Keep on the good work, and I'll let you know what happens in a few years from now. In the meantime, do you have a message for my colleague and others regarding long-term control of diabetes? So that's the one question. And of course, I'm alive today because of long-term control of diabetes. I've had diabetes for over 75 years now, and I hope to last a little while longer. I don't have any new complications of the disease since I started controlling it. I didn't start controlling it until about 1971, 72, where I had it for 26 years. So I still have intrinsic minus feet, and I think that's about it. And one frozen shoulder, but no retinopathy, no kidney disease, the kidney disease reversed, etc. So if you can keep normal blood sugars for 75 years, you'll remain in good shape, unless something else happens to you. Next question. We are increasing the basal doses of our kid and suspect that he is becoming insulin resistant. What is the dose in units per kilogram that you can consider insulin resistant in a kid, and is it advisable to administer metformin? Well, I see insulin resistance when kids go into puberty. You haven't specified the age of your kid, but when they go into puberty, and especially when they're growing, we see spurts of high blood sugars, as if they're making growth hormone for a few days or a few hours, and they go high, and we have to chase the blood sugars to get them down. I do give these kids metformin in an effort to lower their insulin resistance. And the question in my mind is, does it really work? It seems to maybe work a little bit, but I can't guarantee it. Now, if you're giving him metformin, you have to periodically, I'd say every 6 months, check him for B12 deficiency, because metformin can, in some people, impair the absorption of B12 from the intestines. Not in everyone. Thus far, I have not seen it, but I've read about it in the scientific literature. And to check the blood for a B12 deficiency, your physician should order serum B12 level, methylmalonic acid, and homocysteine. If the B12 level can vary rapidly, and therefore we want to double check by looking for certain signs of inflammation that a B12 deficiency can bring. So we look at methylmalonic acid and homocysteine at the same time. It is possible to prevent the B12 deficiency by giving a calcium pill with every metformin pill, calcium pill like Tums. This is a new question. Since I don't know of any way to get regular supply of dilution fluid to make my own diluted insulin, I am wondering if I could treat my mild diabetes with insulin pens used for children. Well, the insulin pens don't have diluted insulin. They can be set to half-unit increments, and the insulin syringes can be set for half-unit increments if you buy the syringes with half-unit markings. You just have to specify that. And using those syringes, if you have good eyes or magnifying glasses, you can estimate quarter units. And the syringes have one advantage: they're much, much less likely to leak than the pens. We've discussed the problem of leakage from insulin pens before. It also is possible to have your local pharmacy purchase diluting fluid from insulin makers or from their distributors. And it's also possible to have a compounding chemist dilute your insulin. There are only certain insulins that can be diluted, and these are NPH, Protamine, Zinc, regular, Humalog, and Novolog. You have said that insulin glargine has 165 times the affinity for IGF-1 receptors, which are present on cancer cells. Where does this data come from? It comes from a study, multiple studies done in Europe, quite a long time ago. I would say about 15 years ago. You could look for it on the internet. I don't have the reports handy, but my recollection is that studies were conducted in 5 countries that have nationalized medical insurance, where they have national records of who had diabetes, what medications they received, and who in the country got cancer. And as I recall, 2 out of the 5 countries showed a substantial increase in the number of different cancers in those who are taking glargine insulin, also called Lantus. So 2 out of 5 is too high a percentage for me. It's one of the reasons that I've never used the glargine insulin. So you can do what you want, but 2 out of 5 is 40%. I wouldn't want to take a chance. I would use Levemir or Tresiba, or if you need diluted insulin, Protamine Zinc, which you could get from compounders or from veterinarians. I'm a type 1. Recently, my son had a morning hypoglycemia. His sugar level was around 45 milligrams per deciliter. After the event, we decided to do some tests and connect him to a continuous glucose monitor for 2 weeks. Monitoring his blood glucose, we often saw that his sugar is on the higher range of the OK spectrum, average of 95 milligrams per deciliter. We observed multiple spikes reaching 150 to 160 milligrams per deciliter soon after eating fruits. His A1C is 5.2, and he has a fasting C-peptide of 0.8, negative for several antibodies. We have a feeling that his blood sugars are high for his age, and he is at risk of developing diabetes. Would love to hear your thoughts. Well, first of all, I'd suggest you read my book, Diabetes Solution, and I remind you something I've repeated over and over, that a C-peptide level only has meaning when you know the blood sugar. And if you really want to make sure that someone is making C-peptide, you should have a blood sugar that's relatively elevated. So you might want to start with making sure his blood sugar is, let's say, 130, and then see what the C-peptide is. It should be above normal, because you should, if you're not diabetic, you should be making a lot of insulin for a blood sugar of 130. So my guess is that he's on the border, and I think it's better to prevent beta cell destruction than to just watch it happen. So low carbohydrate diet, and depending upon his age, usually kids under, say, 14 years of age should have blood sugars of around 70, 75, even 65. And that's what I would consider normal for their age. Um, uh, Again, you should consult with your doctor, and if he's not interested in preserving beta cells, you might want to have a kindly pediatrician who is willing to read my book. My healthy 8-year-old is a type 1 diabetic since he was 3 years of age. We are doing low carbohydrate, high protein now for 4 years, following your book. A1C is 5.0%. We already use vitamin D supplements. Now, I don't know why they're using it, but my guess is that he doesn't get out in the sun very often. Just wondering if it would be worth it to add some insulin mimetics to his healthy diet, as are alpha lipoic acid with vitamin and primrose oil in order to decrease daily insulin and make easier the glycemic control. Well, it's a good question. I would say it would only be if he's getting unexpected fluctuations that we see with growth spurts and also around puberty. And there's really very little you could do to prevent these fluctuations. So maybe if you make him more sensitive to his own insulin, especially if you preserve beta cell function, might be of some value. So the R-alpha lipoic acid might be of value. Give it a try. Let us know if it makes a difference. By the way, it's good that you're considering the alpha lipoic acid with biotin, because alpha lipoic acid diminishes the body's biotin supply, and biotin serves a number of functions in the body that are important. How would out of range blood glucose play a part in neurodegenerative diseases? Well, it's a good question, but the incidence of most neurodegenerative diseases, like Lou Gehrig's disease, muscular dystrophy, etc., are not, to my knowledge, especially common in diabetics, but I may be incorrect. Alzheimer's disease does appear to be more common in diabetics, and there have been several papers written about factors that are believed to occur in Alzheimer's disease, causative factors, and whether these are increased in diabetics. There was one study that looked at beta pleated sheets, another study that looked at a T protein, etc. And as I recall, there was some slight indication that these things were indicated in diabetes, but it was hard. The papers I've seen have suggested that there be more studies with larger populations studied. So it's not hard data. We do know, however, that high blood sugars cause neuropathy, which results in destruction of Schwann cells that insulate the axons of nerve cells, and also actual destruction of nerve cells via the aldose reductase shunt that we've spoken of. And since the brain is loaded with nerve cells, I could see that high blood sugars can affect the brain, and indeed many studies show impaired cognition, memory, etc. in people with diabetes, especially in children who grow up with elevated blood sugars. But it's also been demonstrated in adults. And Alzheimer's disease is more frequent in adults with diabetes. But the reason, as I said, is uncertain, not strong data as to why. I am 70 years old and have always been in great health. I have been a type 1 diabetic for 16 years, and following your advice and your book, I have gone from an 8% A1C to a 4.8%. My doctor called me today and said that my sodium level is too low because of my low A1C, and that I need to raise it immediately. Well, there are many causes, potential causes of a low sodium level. Probably the most common would be drinking excessive amounts of water. And there are people who do that. I once had a patient who did not tell me that she was under psychiatric care, and did not stay with me very long, but she apparently told the psychiatrist that I was treating her, and the psychiatrist told me that she was drinking excessive amounts of water and had some serious symptoms. I don't know whether she lost consciousness or not, but she had cerebral edema, I think, and a very low sodium, because the water both dilutes the blood and lowers your sodium, and also causes you to pee a lot, which could lower your sodium. So I would suggest that you have your doctor test you for other causes of low sodium, but first that you keep a record of how much water you drink. If you use water in bottles, I guess it's easy, because you could count the number of bottles you drink each day and write it down on your blood sugar data sheet. And if your doctor thinks that you're drinking too much, you cut down the number of bottles and see what happens to your sodium. I've had a number of patients who had low sodium from drinking too much water, who fortunately were not overdoing it as dramatically as the other patient, and didn't have symptoms, but had low sodium, low chloride, and even low hematocrit from diluting blood. So it's something I keep my eyes open about, because many people are walking around with water bottles, and some of them may be drinking too much. Another problem related to this has to do with the SGL2 antagonists, which require that you drink a lot of water to make these agents safe to use. And taking these agents that can make you urinate a lot can also lower your sodium. When strictly maintaining your program with an A1C at 5.0, is it possible to stop the progression of the diabetic retinopathy and prevent future blindness, even if it's proliferative retinopathy? Well, it's yes and no. First of all, it's been shown that if your serum IGF-1 level is too high and you try to rapidly lower your blood sugar to normal levels from an elevated level, and if you already have neuropathy, you can accelerate the progression or deterioration of the neuropathy. I meant retinopathy. I'll repeat that. It's been shown that if you have an elevated serum IGF-1 level and you already have retinopathy and your blood sugars are high and you try to rapidly bring them down, you will make your retinopathy worse. So part of the situation depends on your serum IGF-1 level. If it's high, you don't want to bring your blood sugars down rapidly, but must do it slowly. I've had several patients with proliferative retinopathy whose retinologists wanted to do laser treatments. And I asked the retinologist to give me 6 months of normal blood sugars before they would reconsider the laser treatments. And we were able to reverse the proliferation, reduce the number of these many microscopic vessels that seem to occur in clumps, and literally reverse the proliferation with normal blood sugars. But again, you have to be careful and check the IGF-1. And just because it happened in a few patients for me, I can't guarantee it'll happen for everyone, because it's only been a couple of patients. I can't say that 10% of my patients had proliferative retinopathy that reversed, because they didn't have the proliferative retinopathy. I don't have a big sample. Is your experience with intermittent fasting harmful to type 1 diabetics who use this for weight loss? Is there anything to be concerned about? Yes, there is, because according to some of the reports, maybe many reports, these people lose fat and muscle mass, and then when they start eating again, they regain the fat mass, but not the muscle mass. So it's not a wise way to lose weight. I would say that the wisest way is to reduce carbohydrate and get a lot of exercise. It may also help to take a few medications like metformin that lower insulin resistance so that you can maintain your muscle mass but have lower serum insulin levels that might be maintaining a fat mass. How can I find a new endocrinologist who follows the Bernstein method of treatment? I live in the Washington, D.C. metro area and wasn't sure if you know a good doctor here. Unfortunately, I don't know any MD in the USA who practices my methods. They may exist, but I don't know them. I know of several who speak as if they practice my methods, but I can't attest to what they actually are doing with their patients. One big problem is that to teach a patient, you need a lot of time, and doctors cannot afford the time. They are not paid by the minute, they're paid by the procedure. And if they can do procedures or tests that generate a lot of income, they can survive. But if they attempt to sit and talk with the patient as I do, they can't survive. And I have to literally deplete savings from years in another career where I wasn't a physician in order to support my practice. So I really don't know what's going on elsewhere. I suggest that you read my book, use my book. You probably will not be able to get an endocrinologist to read it, but you might be able to find a family practice doctor who's willing to prescribe the medications that the book recommends. By the way, in the light of the COVID-19 epidemic, I'm treating my patients virtually using Skype, and it's working. I would like to be able to examine them, but that's for the future. And they're doing very well, even though we're treating them remotely. My husband has finished reading your book, Diabetes Solution, and couldn't help but notice that you weren't a fan of NPH insulin. Do you still stand by your statements? Do you think I should continue with NPH insulin or switch to Humulin R insulin? Well, the husband may have read my book, but the mother, the wife, who's apparently diabetic, probably did not read my book, because NPH is an intermediate acting insulin that in the past I have recommended for very small children who require diluted long-acting insulin, and we give them NPH diluted, might be 1/10 of a unit, 4 to 6 times daily to act as a basal insulin. It's not that I'm an enemy of NPH. If it's working for this woman, fine. But our insulin is a rapid-acting insulin. It has nothing to do with the NPH, and confusing the two, substituting one for the other, shows a lack of knowledge about diabetes, but also that she probably has not read my book. The R insulin we use before meals, and also for some people for correcting elevated blood sugars. Well, that's it for now. Thanks for watching. Our next episode of Dr. Bernstein's Diabetes University will be Wednesday, December 29th, just before the end of the year. We'll see you then. Have a good month.